but it's also very challenging, and it can be frustrating and quite exhausting for everyone involved. Behaviors are one of the most difficult parts of caring for someone with dementia, whether you're an in-home caregiver or you're someone in a professional setting. I try to look at each situation as not what behavior does the patient have, but what patient has the behavior. So given that one of the four M's is the person-centered planning and knowing who the patient is, that's going to be something I'm emphasizing throughout this. The best strategy is to always try to gain understanding, and with that, empathy for all parties involved. So if you can try to take any behavior you're noticing as communication and a chance to learn about the patient and how to help them, it can go a long ways. So have you ever had a situation where you've looked up to notice someone staring at you through a window? It can be pretty unsettling because you don't know why they're looking at you. When people get to a certain point of dementia, some of them can't even recognize themselves. So imagine if you were this person in this picture looking in a mirror and you didn't know who it was. How would you feel? I would think it would be pretty scary and difficult, particularly for someone with a history of trauma and you feel already threatened in a lot of situations. So what if you felt these things, any of them? Scared, lonely, sad, you had physical symptoms like pain, you were tired, you're bored out of your mind, like many of us are in isolation at home these days, frustrated, thirsty, but you couldn't tell anybody because of your language. You didn't have the words to tell them. They were too busy. You perceived that they were upset with you or angry or frustrated, or you just thought they weren't really listening or didn't care. You might feel this way. I know I would if I felt like somebody wasn't listening to me or didn't understand what I was trying to communicate with them. And this could communicate all kinds of situation. It could be anger, it could be I'm at my breaking point, it could be extreme sadness. You don't know, but it looks like someone who's not having a very good day. So the first thing is that aggression, not violence specifically, but aggression meaning hitting, biting, kicking, verbal aggression is incredibly common. It kind of depends on the study, how prevalent it is. It can be upwards of 96% of dementia patients in one study that looked at behavior over time for 10 years. So you can see it's very common. That could be one incident, or it could be recurrent, but it happens in many, many cases of dementia. These behaviors are things that increase caregiver burden and burnout, no matter what setting they're in. If they're at home, if they're in an adult family home, if they're in the community and you know, the community rescue people are getting involved regularly, or neighbors, or a nursing home. It's just hard to take care of people when they're having these behaviors because it's hard to empathize with them and feel like you want to take care of them, especially if you're trying to give them hands-on care, which is the most common reason when people have violent behavior, is usually when you're trying to provide hands-on care. 5 to 10% of patients will have that well-giving care. These are some of the factors that have been associated with aggression in dementia. There are many of the same things that I was saying. What if you couldn't communicate with someone, you're feeling these things. Some of the other things can be if the person has psychotic symptoms, like they're hallucinating, they're believing that something's happened to their stuff, that you took their things, someone's hidden them, someone's trying to break in, they're paranoid. Or if they've changed environments and they don't recognize anybody, or the routine is completely different than what they're used to, they're afraid. Delirium is a really common associated factor with violence because they're often really confused. They can't check reality because they don't know nothing to hang their hat on. They're just really sick usually, or in pain. Noise is also probably an under recognized factor. When it's a busy, noisy environment, it can be really overwhelming for patients. And I think that's something that we don't always remember, including in the hospital when, you know, ICUs are really noisy and busy places where there's lots of alarms and, you know, people running in and out of rooms for acute care. It's really hard. So just knowing someone's moved from one setting to another is something you can predict that could increase their aggression, whether they've had it before or not. We just had a consult patient yesterday that we had seen before in the hospital, and they had been seen, started on some medicines, were doing great, weren't having any troubles. Then they moved them onto a different floor, and we got reconsulted because they suddenly had new behavior when nothing else had changed except they had moved floors. So it was an entirely different staff, and they didn't know how to work with the patient or what had worked before. So it wasn't really a new consult, but it was just an example of one transition for that particular patient and how easy it can happen that behaviors pop up. I don't know about you, but this is how I feel a lot of days these days with a lot going on with all that's happening in our world right now. And I have all my you know, cognitive faculties most days. But imagine if you were having memory trouble or you got easily confused, and then you had the environment was busy, or you had people talking at you and you couldn't understand what they were saying, or they were being loud. You can imagine that it would be really overwhelming and frustrating, and you might feel this way. This is a way of talking about things that what I would consider is debriefing after something happens, but it's also useful in looking at ways of identifying behaviors that are starting to lead towards incidents that will lead to aggression or violence. So it can start to be very minor things like more verbal aggression, which is a little bit easier to handle because it doesn't involve, you know, violence towards other people. um, in the middle of a violence episode is not the time to try to figure this out. It's after the fact, or because you're anticipating things are going to get worse. So what was happening before the incident? So these are things you can ask caregivers or you know, somebody at home with the patient. You know, did someone just have a fight in the, you know, environment? Did the caregiver and the patient get in a verbal, you know, tiff? Did someone that the patient doesn't like very well or loves a lot just visit and then leave? Did they get into any kind of argument? Was it noisy? Were they in an environment where the nurses were dealing with a medical crisis and another patient, where there was a lot of in and out activity, lots of vital signs in the middle of the night? Do they have a new roommate maybe that's playing their TV loud all night long and the patient's not getting any rest and they haven't mentioned it and no one else has noticed it? Did the person have 3 doctor's appointments in one day? This is kind of a common thing where people will try to do it all in one day to get it over with, so they don't have to keep going out in the community with the patient, which is often hard to manage, getting in and out of the house and getting dressed for the day. So they'll sort of stack appointments, and then by the end of the day, the person's just exhausted. And you know I'm like that. If I have a huge panel of patients and I get home and something else happens, it's overwhelming. Was there something out of normal that day? Like, was it a big birthday party? Even though it was happy, was it just like too much activity for that person, whether it was them or they were attending something for someone else? Do they have a new caregiver? Like I mentioned, the switching floors, or they have a new person coming in to help at home with their wife, so their wife can go out and do their own thing, or their husband can go play golf one day. You know, has there been some kind of change? Did they just get out of the hospital? Maybe their medicines have changed. Did they get put on a new medicine, or was one taken away? Do they normally smoke when they're stressed and they can't smoke because they're now in a nursing home that has no smoking? Or are they not able to access alcohol, which is maybe another way they used to cope, and now they're not in a setting like that, or they're in withdrawal? And you know, what things do you see? Are you observing anything in them looking back? You know, did it seem like they were pacing? Were they looking frustrated or anxious? Were they limping? Did they have facial tension? Or were they tapping their leg or pulling their hair a little bit? Something that didn't seem like you weren't really clued in at the time, but looking back, you can see that maybe there was something going on. And then if you're the caregiver, how were you feeling? Was that a particularly bad day for you? Did you have a lot of sick patients? Were you, not feeling well yourself? Were you in a bad mood? You didn't get enough sleep. You were feeling sad or with, not connecting with the patient the way you want to. That can really be picked up by the patient in nonverbal cues, and they can react to that. And we're not always aware of that at the time, but looking back, we can often do that. Sometimes I tell people that are taking care of people, and this works for me pretty well. If have a day's worth of patients, I'll stop between patients and say, what am I coming from? Meaning, how am I feeling right now? And, who was I with? What was happening? What emotions am I noticing? How is my body feeling? Take a pause, a deep breath, and think, I'm aware of that. And then look at who I'm going to see next and say, okay, I'm not going to carry from the last patient into this room with this other patient what I'm experiencing. It's just a pause that can sometimes help center you so that you're not just running from one room to another to see another patient where you're overwhelmed from the other situation, but it really is not the other person's fault. So it's just something I recommend thinking about no matter what setting you're in. I think that healthcare providers, and I mean that in the broadest sense of the word, anywhere from physicians to nurse practitioners, nurses, aides, social workers, anybody who's involved in healthcare or contact with patients. Look at what we can do to provide people with guidance about what to expect as people's dementia gets worse, because these behaviors are so common. And I think most people aren't aware of that until they're in the midst of it. And then they may blame themselves or think this is just part of what I signed up for when I said I would keep mom, dad, husband home. And they feel guilty or like they're doing something wrong. So they often won't ask or tell you unless you bring it up. So I kind of look at it like the way we look at asking about sexual trauma or domestic violence or suicidal ideation. Most people aren't going to tell you that unless you directly ask them. So I think just including that in any interaction you have with caregivers, including in other settings like nursing homes and adult family homes, if you are somebody that goes to different places, just asking how things are going. Also asking caregivers how they're doing, because caregiver burnout is incredibly high in all these settings. And just to be acknowledged that it's a really hard job and empathizing with that and asking what kind of help they have can go a long ways. Many people don't know there are a lot of resources out there, and they really don't know what to expect. And so just education and providing, empathy and offering some ways to help can really help people feel a lot better. Because most people want to do a good job and they don't know what to do is the situation. So I want to say it's nice to have, maybe easy for me to say because I'm an office set up like this, but having resources right there available, not like here's a website, you can go look it up. I'll talk about a few resources later, but I can't emphasize the Alzheimer's Association enough, because they have so many great things that you can give to patients and families right from your office to look at and remind them about some of the things that you talked about. And they have a lot of supports available and education. So I'll talk more about that. Just educating people about dementia in general, and many people who work, say, in nursing homes or adult family homes really don't have much education about dementia and what it means. They don't know what that does. And so just telling them, they might not be able to even process what you're saying, or they might not have the words to tell you. They have difficulty with memory even, is enough to tell them some information that might help them. And commonly in some other care settings, including at home with caregivers, there's sometimes some language barriers and things or cultural differences that people aren't aware that are impacting the patient too. That comes up a lot in nursing homes. These are some things that dementia patients have said. Some of them can communicate. Maybe they cannot communicate at the time they're having agitation or violence. But if you ask them later about what was going on, these are some things that they would tell you. So that they felt rushed. Maybe they felt like the person was angry with them that was working at them, or frustrated, or they felt like a burden, so they didn't want to say anything about how they were feeling because they felt guilty. They're feeling sad and lonely. A lot of patients will pick up on the change in the dynamic. Like, imagine you like being around your husband, but they have to clean you up after you have an accident, and it totally changes the dynamic. And you might feel very sad and grieving about that. And that's how you show it, is, you know, maybe you swear at them, or you're agitated just because you don't know what else to do with your feelings. The care was painful. Like, people may not have realized they were moving your arm, that you had a frozen shoulder. Maybe they didn't know that about you. And so when they tried to turn you to change you in bed, that really hurt. And so that caused you to strike out. You're bored. You don't know what to do with your time. You just, you know, no one's offering anything stimulating. So you're just kind of out there with your language and your words, and frustrated. It's noisy and busy. We talk too fast. I know I do. I do this all the time, and I still have to be reminded to slow down my speech. I have a lot to say usually. So, and just being aware of that, and slowing down. Your pace is enough to just bring the level of distress down sometimes. People feel scared sometimes. They don't know what to expect. They don't know who the person is and what their role is. This person just came at me and started, you know, taking my clothes off. I didn't know why they were doing that, especially people with trauma. They didn't feel like they had any control. They didn't ask me if I wanted to take a shower or not. Maybe I want to take it at night, and they didn't offer me a choice. I had to take it in the morning. I don't like to take a shower in the morning. This is part of person-centered care. Just not feeling listened to. You know, I'm trying to express something to you about how I feel, and you're not empathizing. You're not giving me any indication that you understand at all. And I'm scared, I'm lonely, I'm sad, I'm really angry at you, and I don't know where to put it. This is, I mean, I can't tell you how many times I've seen this, not just in patients, family, you know, in the nurse's station at the hospital, when it's just like a really long haul with a patient who just will not do what you're trying to get them to do, and you're just trying to help them. It's just, you know, it's hard to know what to do with your emotions. It can really feel like an impossible situation on both sides. But just being willing to have a conversation about what is it that's making this hard, what would help you, can sometimes just open a whole dialogue about ways you can try to support the person. Patient, caregiver, you know, system of care. Lots of roles for that. So violence is it's really scary when you have someone in front of you that you're worried that they're going to haul off and hit you. It is very scary. And so I don't want to minimize that by suggesting that, oh, we're just going to talk about things and figure out a solution. When you're in it, it's really scary. Which is why caregivers often don't bring it up. They just think, this person isn't going to understand what I'm saying. They're not going to believe that this person does this. They're ashamed. They think that they've done something to cause them to act this way, and they're not doing it right. So they don't want to appear like they don't know what they're doing. So again, they are not necessarily going to volunteer that. And that includes in people in professional environments. Some aides won't talk about what they're experiencing with people. And there's a lot of turnover in nursing homes. And that's probably part of it. It's very hard to directly care for someone who's trying to hit you and bite you, or connecting, biting and scratching. You know, you get hurt. You worry about your own safety. And people don't know what to do when they're starting to face that situation. What is the best way to deal with this? How do I keep myself safe and not hurt the patient? What am I doing wrong? You know, they don't know. They don't have enough information. People get injured. You know, there's all kinds of patients, nurses and family members that, you know, have back injuries, or, you know, break things just because they're trying to help someone, and maybe they overpower them, or they're not expecting it, so they get hurt. It can be really unpredictable. Even though I can tell you some things that you might observe and try to watch out for, sometimes you don't have a way of predicting it. We used to have a patient in a nursing home I went to, a lady who was in her 60s, and she would just haul off and punch other residents in the dining room. She would just seemingly out of nowhere. Originally, we thought that it was anytime she had a urinary tract infection, but that wasn't always the case. And sometimes it was, but it wasn't always the case. And sometimes she had pretty good language. She could talk about it. She couldn't always remember what had happened, why she was upset. But on a couple of occasions, she said, "I just didn't like their face," which we took to mean their facial expression, some kind of nonverbal behavior that they were doing. She also had a domestic violence history, and on at least one occasion, she said that the person looked mean, and so we wondered if it was she was remembering something from her past, and this person seemed to have triggered something like that. So it was a defense mechanism. So it happened a couple of times. It was pretty amazing that this nursing home let her actually stay there. So they actually let her, offered to have her eat in her room if she chose to. They weren't going to force her to eat there if she didn't want to. And sometimes she wanted to, and sometimes she didn't. And on other occasions, they would have her eat in the dining room by herself. Like she would eat early, or she would come after everyone else was gone, and they would monitor her so that they could see if anyone else was entering. So it seemed she was very territorial, and so if anyone sat at her table, or definitely in her seat that she identified, they were definitely at risk. So it can be just over time, and that took us a little while to figure out. It wasn't like we just, we walked in like, obviously it's this. It's not. You have to do some detective work and talk to people and chart things to see if you can find a pattern when it's recurrent. But the most important thing is to make sure in the setting where violence is happening is to keep yourself safe. You're going to try to keep the patient safe as well, of course, but you also want to keep yourself safe and anyone else that's around you that's vulnerable to injury. So that could mean in a care setting, other frail people, if you're at home and you have small children or another frail adult or another adult in general, trying to get them in a different situation while you're dealing with it. Trying to get people out of the way, if you can, is helpful. But and best would be prevention and management in advance, but you can't always do that. So it's nice to know, but you may not have that luxury. This is maybe more for settings where you're caring for a patient maybe you aren't familiar with, like it's not your family member, or you're talking to someone who's not a family member. You can learn a lot just by looking at what information you have available or talking with family members or other people who know the patient. These are some things that are correlated with violence in general, not necessarily specifically dementia, but they are still risk factors because the person may have had these in the past or current. So people drink still, like there's lots of older people that drink a lot, and substance use is known to increase the risk of violence. If there are guns, you want to know if they own a gun, if you're going out into a situation, or to advise a caregiver if they're starting to have violent behavior in the house, if there are guns, to put them somewhere else. We had a patient in my clinic that had a gun in the house, and her husband would threaten to kill her. And it was one of those days where I was like, surely they don't have a gun. But I asked, and sure enough, they did. And so the wife said she didn't think she could get rid of it. She didn't feel comfortable with that. But I talked with the son who was there because she was vulnerable, and the patient had, vascular dementia, and they were quite agitated a lot of the time. And he knew what I was saying, so he eventually got the gun out of the house. It just decreases risk. If they have been aggressive before or violent before, chances are they can get violent or aggressive again. It's not always the case, but it's good to know if they've had a history of aggression and violence. If they have had a history of trauma. So we had a patient at a nursing home once who was fighting every time they tried to take them into the shower. And nobody quite knew why. They were trying to be, aware of, room temperature and any noise, and trying to go slowly, and trying all kinds of music and different things to try to help. And one day an aide was looking through her chart and recognized that she was a survivor of of Auschwitz. And so she had seen people going into showers in the concentration camp. And, you know, you can imagine if you, even in the recesses of your mind, had that experience of seeing people never come out of the shower, that you might be next, you know? So, I mean, that was just an aide happening to mention that, like, this couldn't possibly be it. They decided to give her bed baths, and she did fine. I mean, it was just one small variable that someone happened to pick up. So nothing is too small to consider as a possibility. You always want to think broadly about possible things that go into why people are. Some personalities are just more wired towards violence. So people with antisocial personality disorder who have a criminal history, they also get dementia. People who have borderline personality disorder and still have active symptoms that are running their lives still can be violent towards themselves and other people. People who have schizophrenia, they still have schizophrenia when they get dementia. Or bipolar disorder, they still can go off their medication or refuse to take them. So, I mean, just knowing who it is, that's what I mean by knowing the person with the behavior, is knowing what you're dealing with, knowing what environment you're walking into. And because you can also use it as a tool. You can say, you know, it sounds like this is really scary. I wonder if you've had a scary situation before, and or talking to the family about that, or a sister or brother or somebody that knows them, what would help? What relationship stressors have there been? Or is there more tension between a parent and child, or someone's ill and in the hospital? Is the caregiver preoccupied by another issue in the family and isn't attentive to the patient? Some change that's happened, someone moved away, someone died, a pet, a family member, a spouse. They may not be able to verbalize it, but they may be so upset and unable to put it anywhere that can be a stress and lead to aggression. These are some things you can try to do, and de-escalation just means trying to bring down the temperature, so to speak. And it doesn't always work, and it's not always appropriate, depending on what the situation is. But commonly, these are things that help people settle down a little bit, so that you can at least have a little bit of a conversation. Try to reassure them that they're in a safe place. People who are psychotic or thinking that they're in danger and expressing that, looking very anxious, often if you can just reassure them that they're safe and they're not in danger and that you're going to help them, that can help a lot. Because they may just feel like there's no one there to help them. Don't get too close to them. If it's safe and you're not, you know, they're not going to roll off the bed if you walk away. If they're just escalating and you're, you know, have some social distance and then add a little bit, because that way they don't feel like you're crowding them and getting too close, because that makes them feel trapped. I can't emphasize enough, if you're in a situation where you're in a room, to try to provide equal access to the door. So don't put yourself between the door and the patient, because you are going to get run over if they're getting out. And it has happened many times. Just try to figure out a way to move them so that you're sort of talking to each other, but side to side, so you can get out and they can get out. You know, that's in any situation with any kind of patient, not just dementia. If you are in a situation like in a hospital or a clinic and you have the suspicion that someone is going to be violent, or that's why they're coming in, or this is what you're going to see them for, don't let someone know that you're going in to see the person. If you're really worried about them being violent or aggressive, don't go in there by yourself. If you're in a setting where you can have somebody with you, another provider, you know, if you're in a hospital and you need security, don't underestimate that. You may need that, especially if somebody has a violence history. You may feel like it's better. Leave the door open. Don't close the door, because no one's going to hear you or see what's happening if you don't leave it open. And it also provides an exit for both of you if the door is open. Try to approach them calmly, with a quiet, not quiet voice so they can't hear, but just don't raise your level of emotion and volume of your voice to theirs. Try to bring it down, because sometimes just by doing that, they have to sort of settle down so they can hear what you're saying. They're like, what did you say? So that it sort of automatically lowers their agitation sometimes, not always. slow down. I'm telling you, slowing down will make a huge difference for quite a few patients. Assure them you're not in a hurry, that you want to understand. Tell them you understand how they're feeling. If they're delusional, you don't have to say, I believe you. You know, I know someone took your stuff. That's terrible. I would not buy into that, because then you're automatically, you know, expected to fix it. But, you know, you can identify the emotion and empathize with the emotion. That's really important. You know, I see that you seem to be scared. I'm trying to tell you you're in a very safe situation. Offer them some choice. Do you want to keep taking a bath, or do you want to not do it now? So, you know, sometimes they'll just say, not now. You know, it might be enough to say, okay, we'll do it later, and walk away. Very few things really are emergent that you have to do them right that second, really. And mostly it has to do with us and our schedule and not their schedule. So we get into, you know, you have to do X, Y, and Z before change of shift, or because they haven't had a bath in 3 days. And obviously there's issues around like skincare, and you don't want skin breakdown, and, you know, they may be incontinent. You can't just let that go constantly, but you may be able to approach it at a different time. One of our case managers was talking to me one time about shower times, and he's from the South, and said that, you know, people from the South don't shower in the morning. They do it at night because it's hot and you get cleaned up before you go to bed. So he said it could be like, you know, maybe just knowing somebody's from like New Orleans, and, you know, it's a hot day and it reminds them of home, and you're trying to put them in the shower early in the morning, and they like to go at night. They may not tell you that, but it may be like just a hypothesis that you could use. If someone's had trauma with dogs, like, don't bring a pet therapy in, you know. Just knowing, this is again, knowing the history. This has happened before, where we're like, oh, look at this cute dog, and the person just, you know, they were in the civil rights movement where dogs were used to, like, you know, harm people or back them out of social situations. So it's you can't always know this, but if you know ahead of time, you may be like, well, that one's probably not a good idea. Make eye contact, but if they're very threatening, don't keep constant eye contact, because that can be perceived as a challenge. So especially if they're psychotic, and make eye contact. Don't, you know, don't look down, or don't look away and refuse to make eye contact. But if they're very, very agitated, like you can see it, don't stare at them and just, you know, because that really, it really can be perceived as you're ready for a fight. Common things that happen are, and you can see this when you observe, usually people caring for people at home, but not always. A lot of times people will try to convince the other person that they're not doing things right. So, you know, they're trying to help, maybe in the kitchen, load the dishwasher to keep them busy, but you're telling them, you know, you're doing it in the wrong order, or, you know, you're doing it wrong. They try to tell you something, you're arguing that's not true. You're, you know, you're aggressive with them, or you don't care about me. Yes, I do. Back and forth, anything that's going back and forth, it was perceived as like adversarial. Don't use complex questions. A lot of times, and I find myself doing this too, so it's not, you know, it's just being aware of it. Like, don't put 3 requests to do something in one sentence. Start with one simple basic sentence, just because the processing time and then trying to think about it all and whether you want to do it is, you know, it's difficult when you have cognitive problems. It's just, you can't process that much. And they often can't understand all the words. Try not to take their behavior personally. It's not usually meant to be threatening personally to you because they're angry with you. They're just usually scared, or in a situation they don't know how to express it. So it's hard not to, when they're yelling names at you, when they're, you know, seeming like they're just hauling off on purpose to hit you. But try not to take it that way when you're in that situation if you can. Just try to say, this person's really distressed. I'm trying to empathize. Try to express that to them. If it's noisy, if they will move, just say, hey, let's go to your room, or let's go to a different part of the house. Let's go outside and sit on the patio. Just taking them out of a different situation that might be overwhelming for them. Someone has the TV on loud in their room, or there's like a huge medical issue going on, and in the dining room and it's really busy and lots of people and everyone's distressed about it, try to get them to go somewhere else so that they're more quiet. Don't try to keep doing a care if it's safe to leave that situation, then walk away, come back later. Just say, I'm going to go out of the room for a little bit. I will be back. Reassuring them that they'll be back, but stopping what you're doing. Because often with the care, you can reapproach it and do it later. It may not be a good time. And if it's safe, that may be enough to stop the behavior. Make sure that I mentioned this before, but make sure that you try to move people away from the area. If it's getting very escalated and people are acting very violent, you want to try to move people away from that. You're unlikely to get that person in that situation where they're very, very aggressively, acting like they're gonna hit, or you're probably not going to get them to move. You're probably going to have to move other people or yourself some way. Try to look around your environment as you're noticing this is happening, just to be aware of what could be a weapon. It can be anything. Someone threw a chair at me in the emergency room once, which I didn't expect. And I didn't think it was possible for that person to pick that up, but they were pretty angry. And I didn't see it coming. It really hurt, and it could have been worse, I also one time turned around, I was using an interpreter phone and interviewing a patient, turned around and their fist was like literally right here, almost hit me. I had no idea. I didn't know what I was saying was upsetting them in some way or something about my behavior. So I've had my own situations where I was not paying attention. And I just use that now to say, what kind of situation am I walking into? So some of the stuff I'm telling you is stuff I've made my own mistakes, and so I can tell you some things that I don't do anymore. Like I don't wear scarves on the hospital consult service. Can catch onto it, strangle you. I don't wear loopy jewelry or necklaces because I don't, you don't know what they're going to do. Sometimes there are heavy things in the environment, like a vase could get thrown, or I've talked about guns and making sure that wasn't in the environment. If you're having an argument at home in the kitchen where there are knives, try to move to the side where there aren't knives. Try to switch positions with the patient. Just to be aware of you can't always tell what they might pick up. It might be unpredictable, but just kind of be aware so you could duck or move out of the way. Or say, would you mind if I took that from you? Because I don't think we really need that right now. Sometimes they'll give it to you. Offer them medicine if you have that available. A lot of times people will have things that they have at home for other situations that's meant for behavior if they've had something more minor before. It's okay to offer to see, would you like to take medication? Some patients recognize that certain medications do help them feel better, and so they will take something, and that can sometimes help. Knowing what might comfort them. So if they're scared and they have a dog in their house, and that's their favorite pet, just trying to distract them. Hey, let's see what Willie's doing over here. What do you think's going on over here? I think he's pretty upset. You can kind of work towards that. Or if you know that sitting in their favorite chair is something that they like, or they like hot cocoa, and maybe if you offered to give them, would you like to have some cocoa in the dining room and put on a Netflix, something like that. Just anything you can try to distract them. Okay. These are just some, this is a transition into some non-pharmacologic things that you can do for people. Some of these have been studied. They're pretty hard to study because they're not always standardized, but I'm going to tell you some things that have some evidence base, whether it's just case reports, or there have been some studies of it, and some have more evidence than others. The key thing is that most of these are not dangerous. They don't harm people. They're meant for well-being. So on the principle of do no harm, these can only help the person. They don't work fine, but you can say that you've tried some things, and some of them work quite well for certain patients. A consistent routine is really important. So just the transition into different environments, that's alone can be enough to upset a routine. So when you are taking someone into a care setting, or, there's going to be a move, it's good to tell people, you should probably tell someone what a typical day is like, what seems to work for them, what time of day is best for them for certain things. So a lot of times people do well for appointments, late morning, early afternoon, but not late afternoon, not first thing in the morning because you're trying to get going. So just knowing what is the optimal time period for certain things, and what has worked best going into a new setting is very helpful. Clutter bothers everybody. It's also dangerous. So if there's a lot of clutter around, that's enough to sort of just distract people and make them feel discombobulated. They can trip over it, they can throw it, there's all kinds of things. So just trying to clear a space, trying to make it comfortable, have just what you need, keeping things quiet if that's good for the person. Some people like a little activity, so it's not entirely quiet. So again, knowing the person. Exercise is actually has a lot of evidence for that. It helps with people getting daytime light exposure if you can go outside so that they sleep better. It expend some energy that they might have if they're sitting all day and they're sort of cooped up. You can feel restless and feel like you need to move your body. And if you have arthritis, if you sit too long, it can hurt. If you walk, it can kind of help. So just small things like that. It doesn't have to be you go out for a 2-mile walk. You can go for 10 minutes. You could go 10 minutes, every hour or 2 hours. Usually that's dependent on staff if you're in a setting. But if you notice it helps, it's good to do that regularly. Or it could be, a stationary bike. It could be doing some stretches, chair yoga, sit and be fit on TV, anything that they've liked to do before, throwing a ball. You've seen some of these activities, I'm sure, in some settings, and there's reasons for that. It offers a distraction, and it also feels good. Offer them foods that they like, or check in if they want to have a drink. People aren't going to tell you they're thirsty. Older people don't get thirsty until they're really dehydrated. So just see if they'd like something. Maybe they'd like a cup of tea or a cup of coffee or some, something that, maybe their favorite fruit is strawberries. Maybe you have some strawberries that you just got. Just anything you could think of that might bring them some happiness or make them feel a little better. Try to keep your eyes open for nonverbal cues for physical symptoms. So a lot of times we're just going about our day and we're kind of busy. We're not really paying attention. So just, again, try to be intentional sometimes about pausing to see if we're observing. A lot of times, like on the psychiatry consult service in the hospital or else in the nursing home setting, I'll just arrive and sit and look around for a while, see what's going on. I don't introduce myself. I just sit there and watch what's going on in the environment, just so I have a clue of what the person's dealing with, or how they're acting before I even go in. What are they doing? Are they talking to themselves? Are they barely able to stay awake? Are they fidgeting constantly in the bed? Do they look uncomfortable? Has their call light been on for about 2 hours? I mean, I'm exaggerating, but no, I literally have sat there and watched a call light be on forever at a nursing home. And I'll go alert someone. Usually they're busy and it's not their fault necessarily, but the person's trying to ask for help. And so being attentive to that. Just observations of environment are huge. It's very hard to do that when you're facing someone who is coming from a home setting, say into your office to talk to you about what's going on at home. But you can kind of pick up on interactions between the patient and their caregiver in the room. You can see that a lot. The tone. Does the person interrupt their family member that has dementia or try to talk for them when they're trying to express something? Do they sound angry or frustrated? So you can kind of pick up on that too. Aromatherapy has some evidence as well. I think what I read was lavender and lemon type or citrus smells are the most common, either in like a diffuser or else on things that you apply. That one study that was talking about aromatherapy was also with massage. It was like in lotion, so they weren't really sure if it was the scent or if it was the massage. So it was two variables, and they weren't sure which one. But those are pleasant things for a lot of people. Some people will not like that. So if someone has a history, again, of trauma, or they perceive that, that's some kind of threat, they may not like that. So you do have to be aware that, that's not going to be for everybody. Pets, I mentioned, if you're in a setting where either you have one in your home setting and that's something that the patient really enjoys, making sure they have contact with the pet. If they're in a setting where you could bring the pet in for a visit, a lot of nursing homes will let people do that with permission. It's nice to bring that in, or maybe just have a FaceTime where you show the pet, talk to the pet, or pet therapy. Sometimes people will bring pets to the nursing home that are trained for that kind of interaction. I remember I had a perception once that a patient was happy that a cat who happened to live on a dementia unit was in her room on her bed. I said, well, that's nice. Moxie's keeping you company. And she goes, I hate cats. So that was clearly, I put my foot in my mouth right away. I said, well, let's have Moxie leave. So just, asking them if that's okay or if that upsets them, or trying to observe if they seem really frustrated if the animal's around is also good to recognize. Music can be really helpful, but I want to emphasize that usually it's music of choice of the patient. So you want to ask them or the family members what had they enjoyed before? Do they have specific types of music that they like, or things that drive them crazy? Like my mom, it would be like anything with an electric guitar drive her absolutely bonkers. So I know that for sure. A lot of times people have things on for staff in an environment to keep, it's more fun to work with music, but some people don't like that, or it's too loud, or they're yelling at each other from around, the nursing home because they're trying to talk over the music. We had a patient in the ICU that had music on, and we asked the patient, did you want that music or was that the nurse? And he said, oh no, I like it, it's good. So we asked because, if I were a patient and someone had music on I didn't like, that might really agitate me or just put me on edge enough that if someone then tried to do one more thing with me, that would just be, the last straw. So just being aware of that. Some people like complete quiet, no music, and that's helpful. So just knowing personality, trying to get as much information as you can. I've seen lots of great care plans in charts in a spot where had I not been looking through the chart for other things, I would never have found it. So I'm not sure whoever sees that. So I've also seen some they're excellent, but no one sees them. So how could possibly anyone use it? I've also seen some excellent ones posted in people's rooms at the nursing home, in the hospital, especially for people who can't really speak. It's usually done by the family or someone who knows them well. They'll have maybe a little blurb about who this person used to be, what they did for a living, things they enjoy, things that aren't as enjoyable, how they like to be addressed, people that are important in their lives, maybe their phone numbers, so that if you needed to call them. And that you have to ask permission to hang that kind of thing up in a room. But for me, if I've had a number of occasions where that's a good, helpful starting point for de-escalating somebody or starting a conversation with them. Oh, tell me about your daughter, or, I saw that you used to be a plumber. So we had a patient in the nursing home once that was becoming a problem because he would go around to different rooms and take the sink apart. He would unscrew all, and water everywhere, and the sinks wouldn't work. And he was a plumber. We found that out. And so we just got him a bucket of plumbing stuff, like a tray of plumbing stuff, and sat him at a table and said, could you put these together for us? I think it would be really helpful. So it just gave him something to keep himself busy. That was something he enjoyed. That was like what he was doing, but it was more controlled and it wasn't causing a problem. So just even basic things, like maybe somebody was a homemaker and they liked cleaning. So another patient we had in the nursing home who was quite busy all the time, getting into everybody's rooms. And when you tried to redirect her, would get really, really upset and aggressive verbally. She just liked to walk. We found out she used to walk 4 miles a day outside of her house in her neighborhood. And so she just really liked to walk, and she is in a secured dementia unit. She couldn't get out. So she's just going around and around in circles just because she likes to be active. And so, we said, well, would you like to do something, to try to help out today? And sure. And so they give her a dust cloth and she'd go around all the banisters while she's walking, and, she kept busy that way. Just trying to observe things that you see that you might be able to incorporate. We also had a lady that used to be a nurse who would be constantly anxiously intrusive into the nursing home, and she would just get really, really upset if you tried to redirect her. She, she just wanted to engage. She just wanted to be a part of the nursing team. And so we found her a bunch of ACE bandages and said, could you wrap these up and put them together because they're kind of a mess. We need to use them for some patients. And she sat there, she'd do them. We'd bring them into the office, all done. Great. And then she'd go out and come back in all anxious. And while she was out, the nurses would all, shake them all out so they'd all be undone again. And then, oh, we found some more bandages. Can you work on them? Which, it might be a little bit tiring to do that, but it kept her happy. And it was really pretty much kept her busy for quite a lot and kept her from getting agitated. So just small things like that. You can try on anything that you can think of. Just kind of know what they like to do. If they're a hands-on person, if they like to talk to people, if they, if they're a writer, maybe you try to get them to write you a poem or to draw you something, a picture, maybe they're artists, you can get them some art supplies, those kind of things. This is just a picture of some activities, ideas. The glasses are to remind me to talk about sensory deficits. So you can imagine people with hearing deficits in the hospital right now trying to hear what their doctors are saying when they usually use people's mouths to try to help them cope with hearing or their cognition. This particular pair of glasses would be fine, except that they're also very dirty. So I don't know if you could possibly see through them, but just knowing if they usually have hearing aids or glasses is like kind of a standard thing for like hospital for delirium in any setting, so that communication, because of sensory deficits, is not part of the problem. So if you correct those, at least you have a decent chance of communicating as well as you can with that patient in that setting. Maybe you try to figure out if somebody likes to be more by themselves or with other people. Some people are very lonely and like to be around people. They're agitated because they're bored. Me, I think the lawn chairs sitting there with a magazine looks awesome. So for me, that would be comfortable. I'd like to go outside. I'd like to be in nature. I'd like to be left alone. I don't want to be asked to do anything. We actually have a conversation pretty regularly on our geriatric team about things that we want people to know about us when we go into assisted living or another setting. Like, I don't want to be made to walk to the dining room. I'd rather have the choice to eat my room. I want to have a glass of red wine every night. These are not mine particularly, but people will say this. One nurse practitioner who's quite active, she likes to exercise. We said, Katie, you need a rowing machine in your room. We would come up with our own care plans for each other. Or what would make us happy? Like, it would make me happy to be able to have a square of chocolate, after my dinner, or, to play a certain kind of music. So just to have those kind of conversations with people in your lives or people that you have as patients, it really helps a lot to know what would help them. The babies, this baby picture reminds me of a patient we had in the nursing home who would try to exit seek all the time. And I actually thought he was a visitor to one of the dementia patients because he had a tag on, but he was the patient. But I saw him interacting with a man with one of these babies, and he was holding that baby up and talking to. I mean, he was just in seventh heaven. He must have been the greatest grandpa and dad ever. He just was so engaged, which I don't normally think of that for men, I guess, and that's maybe sexist on my part, but it was just amazing to observe that. So the baby picture reminded me of that. Just having something to care for. Same thing with stuffed animals. A lot of times patients who have, moderately severe dementia, they'll do well with that. Okay. Okay, so I put in here because when I was a fellow, I did a talk called "Don't You Have a Pill for That, Doc?" which was my way of saying that's the first thing I get asked. So they're not asking me for a behavioral plan when I come in for agitation. They want something to calm them down that's going to make their job easy in a setting, like a setting for dementia, like a nursing home. And I don't mean that with any disrespect for the people. Obviously, they work very hard. People are exhausted. They have a lot of patients to care for. I understand that. But it's just to remind us that there are many other things you can do than medications, because a lot of medications are much more harmful than things that you can do that are non-pharmacologic. The other piece about medications is One of the things that's been tough in my geriatric career is, people will send me patients that they know what they would like to give them, but they don't want to be the one that takes the risk for that medication. So they'll say, well, they're psychotic and they're aggressive. Can you give them something for that? And they know that they would like to give them an antipsychotic, but they're just like not sure they want to be the one that takes the risk of increased mortality and morbidity in dementia. Sometimes they might need that. Or anything on the Beers list. That's like every medication known to man in older people. So, I mean, you kind of start to wonder, okay, I'll give them a pill, but what is it you want me to give them? A sugar pill? I'm being facetious, but it's actually kind of a serious issue because, we don't want to cause risk or harm to patients, but at some point you may have to give medicine at least temporarily that may not be healthy for them. In order, so acetylcholinesterase inhibitors are not like the thing that's going to help people from getting violent necessarily. This is just a reminder that the only treatments that we have for dementia are acetylcholinesterase inhibitors and memantine. So these are actual medicines that are FDA approved for dementia. So a lot of people have mixed feelings about them because, they don't really cure dementia. They don't really change things. Like they might change things in a study, but not clinically. But for the right patient, sometimes they are the thing that actually can really help neuropsychiatric symptoms. I've had good luck, for example, in people with Lewy body using acetylcholinesterase inhibitors, Parkinson's as well. A lot of times that will work very well for that and also help some of their cognitive symptoms. So it may not be the thing you need in the face of aggressive, violent patient, but it may be something you can think about trying to add so that maybe eventually you can get them off the other medicines you don't like very much that you're trying to give them. Know what kind of symptoms you're seeing. So if you see that they're really anxious and crying constantly and they're reacting to everything, they look really sad, they tell you they're sad, depression is incredibly common. So maybe an antidepressant would help, and maybe they'll be less reactive or less aggressive because they'll feel better. Those are pretty standard, they're common and they're much less dangerous than some other things. Citalopram actually has some evidence base for agitation in dementia. There's been studies of that. The thing that's limited in that case is usually you're not supposed to go above 20 for patients that are elderly. So hopefully 20 will work for you, or 10 even. But it's a good thing to try. So antidepressants are sometimes pretty helpful. Melatonin, if they're not sleeping, is a reasonable thing to think about. Usually people don't have daylight light exposure. They might have day-night reversal. The best thing would be getting them out in sunlight, normalizing that circadian rhythm. But if they can't, maybe they're in the locked dementia unit, maybe you try that. Melatonin can sometimes help. There's not a huge evidence base for that, but it's something to think about. It's actually used quite often in sleep clinics for sleep. Prazosin, if they have a history of PTSD, and I know there's some people listening from the VA, there's been some studies that show some help for agitation or aggression in dementia, and especially in people who have a PTSD history, not necessarily just military, but sometimes other kinds of PTSD. So if you know that they have that history and it seems like they're hypervigilant or they're having PTSD symptoms, that's a good thing to think about trying. And it has a pretty wide dose range, but you do have to worry about blood pressure and falling. Antipsychotics get a very bad name. However, for someone who is actively psychotic, who is agitated and potentially violent related to their psychosis, this is actually a really good thing to use. It's not that they will have to stay on it forever. Yes, we know that they can be dangerous, but they do work for certain kinds of symptoms, and they help people for the time that they need them. So if someone is completely petrified by something that they believe to be true that is not actually happening, these can treat that. And they do have side effects, and they do increase morbidity or mortality. You do have to have a very frank discussion with families and even with patients. If they're their own decision maker, you want to tell them that so that they know. But 9 times out of 10 for families who are making decisions, they don't want the person to lose their placement. They can see how distressed they are. They don't know what else to do. They feel like they've tried everything non-pharmacologic, and so they're willing to give it a try. So if that's the most appropriate medication, that's what you should use. Gabapentin doesn't have a lot of evidence base, but I mention it because it does have some benefit on anxiety. And if someone has neuropathic pain, maybe as a part of their profile, it might be something worth trying as something that covers more than one thing. I'm a geriatrician, so I like to cover many things with one medicine if I can. Trazodone, if they have a sleep disturbance, if it's just that's their sole issue, maybe you've tried melatonin, it doesn't work, or they have a history of using trazodone in the past and it was helpful, that could be something helpful. This is just, I mentioned that abuse, and I mean that in the sense of abuse towards caregivers and towards patients, because aggressive behaviors can lead to violence and retaliation, or just, you know, you are going to do this, and they may not intend to hurt the person. It's just a sign that they're reaching their limit. So you do want to pay attention to that, because we are mandatory reporters for adult protective services for the demented patient if we would notice that. And so you want to be investigating that if there's something that you see that makes you think there might be some kind of restraint or abuse, even if you understand why it could happen. And then it's also to tell the caregiver, you don't have to get hurt. We might need to get you some help. Talk about ways to get support, and then offer staff and caregiver training for other settings so that they can be protected. These are just some of the helpful resources sometimes I tell people about. Care managers, just to try to hire in-home help for people. I've had good luck with those. Alzheimer's Association has tons and tons of information. Pamphlets, you can have them mailed to the patient, you can have them in your office or with you if you go to nursing homes or whatever setting you're in. They have a 24-hour helpline that you can call. They have lots of things in different languages. You can print things off from their website. They have all kinds of information on specific behaviors for caregivers and also for professionals so that you can educate people. That is a great resource for, and it's Alzheimer's Association, but it's all kinds of dementias, and they have so much other information in there. And no, I don't work for them. I just use them all the time. So I really think that's a helpful resource. And then the 36-hour day, if anyone's not familiar with that, that's a great book to recommend to people, similar kind of information. And you can get it at the library or, you know, Amazon has it. So hopefully those are some strategies you can help. I heard that this can be a chatty group, so I hope you'll have some good questions or maybe some examples I can try to offer some suggestions about. But I think keep in mind, this is sort of what we're trying to go for. We want people to be well and happy and have a good end of their life, no matter what they're dealing with, including dementia. So that's everyone's goal, I think. So that's all I got.
Great. I don't have questions yet, but I'm
Okay.
sure some are coming. Donna did mention, she said, thanks for mentioning professional care managers. They're now called aging life care professionals.
Oh,
and
I did not.
a professional organization called aginglifecare.org.
Oh, okay. I'm gonna write that one down. Thank you. It's hard to keep up on the language sometimes, I think, so.
Well, it's good that we're starting to develop those roles and really think about them.
Yeah, I think so too.
So here's a question. How long do these violent behaviors last for? It sounds like the onset can be pretty sudden. Have you picked up on prodromal signs?
Well, the best predictor is seeing other agitation earlier. So if you get a history where someone's, you know, the most common thing is, you know, this is a, you know, X-year-old patient and they've been gradually getting more and more agitated since they've been here, and yesterday hit a nurse. So it's like a one-time thing. You don't really know because it kind of depends on what the trigger was, and you can't always figure that out. So to tell you how long it's going to go on, meaning I assume what you mean is like repetitiveness, or is it going to be recurrent, or like months, or I think that's what you meant. It can vary. So if it's someone who's having like a psychiatric issue, for example, like maybe they had a history of manic. Here's a common one. People are like bipolar disorder in the hospital, took them off all their psych meds because they were in the ICU and they were out of it. And then nobody restarted anything, which is fine. But then nobody knows that history and they're off like their Depakote. And then they're like manic, or they're, you know, so they have a history of violence when they're manic. because they can't control themselves. So, I mean, it depends. It depends on the cause. So the prodromal things would be like, you notice that the person's starting to be more, you know, say they're pacing, or they can't stay in their room. They're starting to get louder with you, or they're irritable. They're grimacing a lot. Maybe they're having a new medical issue. They had a fall and they're hurting, and you know they had a fall, but it didn't seem like anything happened. But then you're noticing that they're starting to get more aggressive and agitated. So it can be, I mean, it can run the gamut. So it's a hard question to answer, a good one, but so it depends. If you can identify that there's a definite cause, then the violence should go away, but it's not always that easy.
Well, sort of related to that, do you have a sense of how often do these behaviors burn out, and particularly in relation to the progression of the dementia?
Well, the most common thing is, as people progress, they get physically less able to be violent. You know, they just don't have the strength anymore. So maybe they stop eating, their mobility is limited, they develop contractures if they're getting that demented. Yeah, I mean, it will burn out only because they maybe physically can't do it. Like they might still be verbally agitated. But they tend to, it tends to wane as they get into the much later stages of dementia. The period of the agitation neuropsychiatric symptoms, unfortunately, can be pretty long. So developing management strategies and trying to come up with things you can try, and it can change over time what they need, is part of managing dementia. It's the most difficult phase. If I have somebody coming in who's of this age, who might, they have a memory problem and they're agitated, I already know they're in the moderate stage of dementia. I don't have to do a mini mental or anything. I know that's probably what's going on. The only other explanation is delirium. So, it's a long period of, agitation is different than aggression. Agitation is really common. It can be anything from just, pacing to like repetitive questioning to wandering, exit seeking, that period goes on a long. The aggression part can, not always that prolonged though.
So Donna just offered some suggestions, such as asking family caregivers to create a list of the person's likes and dislikes, best ways to soothe, favorite foods, favorite music, etc., which can then be shared with the healthcare staff.
Exactly.
The person is hospitalized.
Yep.
I'm actually wondering about what kinds of advice do you offer to family caregivers when the person is still in the home, and how to manage and how to make some decisions about perhaps different kinds of living arrangements?
Mm-hmm. Yeah, it can be, it's a hard conversation to have if you're seeing them together. So a lot of times it's important to try to have a conversation separately with them. I talk a lot with them and educate them about how their inability to have their own self-care can relate to burnout, and how it's extremely normal. Depression's normal. If you can't get your own time or share the load with somebody, it can help enough just to have somebody coming in, or maybe a discussion about adult day health or something like that. The discussion about moving into a different setting is hard, because many people are so dedicated, they don't want their family member to go to a setting like a nursing home. I don't blame them. It's not what most people want for their family member, but just the physical care, like just talking with them. If it's, for example, a spouse, they are aging, maybe they have their own health issues. This is not good for your health. I'll often just kind of look at that. You're caring for them at the exclusion of your own health, and your health is just as important as your family members. So just education of, you need to take care of yourself. That's often the route I go, is to try to make it about their care of them, and not to feel guilty about it, that's appropriate. That's probably the most common in women caregivers, because they're, you're just kind of wired that way. You're trying to, I must do everything. Not exclusively, of course, but I mean, just, yeah. And it's a process. You're not going to like convince them with one conversation that that's probably the right thing. But also just saying, this will only get probably harder. The more hands-on care that the person's going to need, that's usually when things start getting more aggressive, is when you have to physically help them with things. And that's going to start happening. It's inevitable. And so doing it now before that starts to happen, where you're getting more help, is better. So talking about it as early as you can. It's sort of like, I hate, I don't like equating it to sex education, but it's a little like that. You have to think way in advance before you start that conversation, or like advanced care planning. It's good to just say, these are the things that can start to happen. And so start thinking now what you might think would be acceptable to you, and start thinking about where you would get help with that, and we can help. So, yeah.
Can you say a little bit more about perhaps recommending adult day health programs in that situation?
Because you can't entertain someone constantly if they're at home with you and you have your own things to do. And often people like to be with their peers, so they might really enjoy some of the activities that they have that you're not going to be able to provide. Just having someone that's not you, so that you can have time away from them, and then you come back together and you enjoy your time together. So, say the person was a social person, maybe they used to go play cards with their, poker or something, or they were in a church circle or something like that. They might like to go spend some time with other people, and you might have to go with them for a bit to get them used to it, and just say, look, this is, it's for fun. You used to do this, these are some people that are going to help you enjoy things. They have different food than I'm a terrible cook at home. They have better lunch than I serve, but a lot of times you'll have to transition with them and go with them to try it out. And not all places have that available, but it's a good resource. They do a good job for people that engage in it.
So Alice mentions, says thanks for a useful presentation, and that the Alzheimer's Association has a great 24/7 helpline and an in-home visit program to support caregivers.
Yep.
And she mentions a referral form on their website. That's with Alzheimer's Washington organization, but I suspect that's also available in the other states as well. Do you want to?
Yeah, I have a patient actually, whose wife has used one of those dementia. I don't know if I think she was calling them the Dementia Navigator. They did come out to the house and sort of talk about the needs and try to help find, ideas for her about how to cope with this person's behavior. Talk to him, get to know him a little bit, and suggest some things that maybe she hadn't thought of. And she's a pretty well-read, educated person. But she found that really helpful. And it's just another support. And they understand that there are often people that have been caregivers before, they have experience with dementia themselves, so they sort of can really get it. So it's a helpful resource. Yeah. And the 24/7 helpline is also people that are aware of what you're dealing with. And it's not emergency care, but it's like a starting point. It's sort of like the crisis line where you can call and talk to someone and just get some relief and support.
Do you, excuse me, do you find clients in the ED due to behaviors are admitted more than not, or are these interventions successful in discharging after observation in the ED?
Well, that's hard because, yeah. So the most common thing I hear, especially from nursing homes, is we sent them in because they're having these behaviors and they didn't do it there. So they saw no problem. So they sent them right back, and who knows what they do in the ED, because the person doesn't really get to see that. The most common thing is people don't send in the information that they're hoping the person will try to fix. So you're coming from a nursing home, well, this is what we're observing. Here are the nursing notes. This is what we've tried. Medications aren't helping, or we've tried X, Y, and Z distraction. These are the non-pharmacologic things we've tried and they're not working. So I don't know that they're often admitted. If they're out of control, or the person bringing them in is just saying, I cannot keep this person at home. I'm afraid for my safety. The person will not listen to me. I don't know I don't want anyone to get hurt, they're going to lose their housing. Those are often things that will lead to someone getting admitted. The first thing they're probably going to look at is whether they have something medical going on, especially if it's a new thing and acute, and that's often a useful use of the emergency room. So sudden onset, that's really common, is to have some new medical issue that's driving that.
And Chris also mentioned that licensed social workers are good at helping link to resources and problem-solved behaviors and help with future planning and providing
Absolutely.
caregiver support.
Yeah, yeah. Yeah, I think that, yeah, they're probably underutilized for that. Yeah, that's true.
Okay, I don't see any other questions, so I think we're going to close off the webinar now. Thank you so much, Dr. Carlson. This was such important content, and as I said, something that we really haven't had before, and I'm so glad that you were available to do this talk.
Yeah,
So
anytime.
thanks to everyone, and we'll see you next week.
Okay, thanks.